In this presentation, we're going to be talking about nutrition in terms of metabolic stress and the stressors being burns, trauma, and surgery. By the end of this presentation, you should be able to outline the responses of the body to starvation and explain what those metabolic changes are during both uncomplicated stress and also hypermetabolic states of stress. You'll be able to discuss relationships between how the immune system functions when we are at our optimal nutritional status and when we are in malnutrition states and metabolic stress. You'll be able to list the nutrients that are required for immune system functions, describe SIRS, and also be able to describe MODS, including the rationale for close monitoring during these situations. It's important for nurses, especially in our context, to understand the metabolic changes that occur during these times of stress as a reaction. An uncomplicated stress is when patients are at a nutritional risk. Severe stress is brought about when there is trauma, disease, and some types of surgeries can also put someone in a metabolic response situation. In order to maintain homeostasis, our body has to respond to these physiologic states of stress, but also the psychologic stress situations as well. And hormonal and metabolic changes will subdue our immune system's ability to protect the body. And these reactions can be seen not only in the central nervous system, but also with our hormones. And the magnitude of the reaction will be determined by the duration of stress. Our gut microbiota, or otherwise referred to as the microbial communities that live in our gut, are influenced by diet and nutritional status. It also has a connection to the innate and adaptive immune system. So think about in terms of for optimal immunity, we need to have adequate nutrients available because a well-nourished body that isn't affected by infection is going to function better than a poorly nourished body. So any compromised nutritional state makes it difficult for our body to mount a stress response and confront any immune response that's needed. So think of metabolic stressors, viruses, surgery, or trauma that can occur. Our body needs an adequate amount of nutrients in order to combat these changes. Now think about how malnutrition specifically affects each part of the immune system. Our skin is affected, the integrity of the skin. Our mucous membranes can become compromised, and wound healing, we know, slows down when we have a patient that is malnourished. Within the GI tract, microvilli become flat and they reduce nutrient absorption during this time. And damage to our GI tract increases the risk that infection-causing bacteria will be able to spread outside the intestinal system. And this is called bacterial translocation. T lymphocytes, or T cells, that are distributed will also be depressed. And more time is going to be required for phagocytosis, or the kill time of phagocytosis, to occur, as well as lymphocyte activation. Antibodies will become fewer in number, and also the ones that you do have are going to be less effective. So it's important to continue to look at the gut microbiota and make sure that your patients understand how it can influence the body systems. Stress sets up a chain reaction that involves hormones and the central nervous system as it acts on the entire body. And whether stress is uncomplicated or complicated, so whether it's from altered food intake or by trauma, disease, or metabolic changes, the stress response will depend on this specific chain reaction. And you may have heard of the phrase fight or flight response, or perhaps it in terms of the general adaptation syndrome, the GAS. And this is a reminder that our body is in a constant response to any minor changes in our environment or any other factor by helping it to have equilibrium by this fight or flight. Now, the body constantly adapts to minor environmental changes because it needs to maintain homeostasis, but the stress response involves an integrated series of actions that include the hypothalamus, the hypophysis, and the sympathetic nervous system. The adrenal medulla and the adrenal cortex are also involved. There are several stress hormones to think about, aldosterone being the first one. This is a corticosteroid that causes renal sodium retention, helps to regulate blood pressure as part of the RAS. The antidiuretic hormone, also known as vasopressin, it's all in the name. It's antidiuretic, not allowing water to exit or fluid, by promoting the conservation of water and salt to support circulating blood volume. Adrenocorticohormone, or ACTH, this causes the release of cortisol to mobilize amino acids from skeletal muscle. And catecholamines like epinephrine and norepinephrine from the renal medulla will stimulate hepatic glycogenolysis to occur, as well as fat mobilization and gluconeogenesis. So with all these stress hormones, they are informing our heart rate, our blood sugar, our blood pressure, the dilation of our pupils, intestinal muscles, breathing, and blood flow overall to skeletal muscles. Starvation, by definition, is a time when we are involuntarily going without food. And if we withhold food from ourselves for any state of time, but voluntarily, this is when we say we're in a state of fasting. But whatever the reason is for an inadequate intake of food and nourishment, the results are going to be the same. After a brief period of time of going without food, we're going to have intervals where our nutritional intake is actually going to be below the metabolic needs. And then our body will react by extracting any stored carbohydrate and fat, as well as protein from our muscles and our organs. And this is to help meet our energy demands. So the effects of starvation are different from the effects of metabolic stress. And so it's important for us to know these differences. So liver glycogen is used first to maintain our normal blood glucose, and then it provides energy for brain and to make red blood cells. But this source of energy is limited. These glycogen stores are going to be depleted within 24 hours. And unlike the glycogen stores, actually lipid or triglyceride stores are more substantial. And our body is able to mobilize this as an energy source. And as the amount of liver glycogen decreases, also the mobilization of free fatty acids from the adipose tissues will increase to provide energy that's needed by the nervous system. At about 24 hours or so without receiving any intake, especially in forms of carbohydrates, the prime source of glucose then becomes gluconeogenesis. This is important. Our brain cells use glucose for energy, and during early starvation, which is 2 to 3 days in, the brain uses the glucose produced from muscle protein. But as muscle protein continues to be broken down for energy, the levels of our branch-chain amino acids, sometimes referred to as the BCAAs, these are leucine, isoleucine, and valine. They're going to increase in circulation. And although these branched-chain amino acids are primarily metabolized directly inside that muscle, our body doesn't store any amino acids like how we store glucose and triglycerides. The only source that we have internally of amino acids is that of our own muscle tissue or lean body mass. Our vital organs, like our our heart and other protein-based constituents like enzymes, hormones, immune system components, and blood proteins. By the second or third day of starvation, we will lose approximately 75 grams of muscle protein because it's being catabolized every day, a level that's adequate to supply full energy needs of the brain. But at this point, other sources of energy become more available. The last important factor is to think about fatty acids. These are hydrolyzed from the glycerol molecule, and both our free fatty acids and glycerol are released then into the bloodstream. Free fatty acids are used. Glycerol can be used by the liver to then generate glucose, which is gluconeogenesis. But if starvation is prolonged, that patient's body will preserve proteins by mobilizing more fat to be the source of energy. When this happens, ketone bodies are produced from fatty acids that are now, this production is being more accelerated. Your body understands the need for acceleration, and the body's demand for glucose then will decrease. And though some glucose is still vital for brain cells and red blood cells, the other body tissues start to obtain the major proportion of their energy from now the ketone bodies. And muscle protein still being catabolized, but now at a lower rate, which is better in the long run. It's going to prolong overall survival. We also have an additional defense mechanism that allows our body to conserve energy, and this is to slow down the metabolic rate. This will help decrease energy demands, and when our metabolic rate declines, so does our body temperature, our activity decreases, sleep periods increase. This all allows conservation and preservation of energy in the body. But if starvation continues, then now our intercostal muscles that are necessary for respiration, they start to become depleted as well. And so now starvation is linked to pneumonia and respiratory failure. So you see that starvation branches way further than just fat loss. But it will continue until adipose stores are completely exhausted. Not only does starvation and stress cause a risk for respiratory infections, but you can see how it affects the other organs and systems. It can involve lethargy and irritability, impaired thyroid function, and hormonal function like cortisol and growth hormone. There is some controversy on whether it affects our cardiac function or not. It does affect our hepatic system and the hepatobiliary function. It alters our immune system like we spoke about, and it can impair glomerular and tubular function. In addition to what we've learned about impaired micronutrient absorption and changes to the microbiota, we will also see reduced beta cell function, impaired pancreatic exocrine function also. Please take a look at table 16.3 to see what actually happens in the initial injury phase, which we call the ebb, and then in the recovery phase, which we refer to as the flow phase. Whether or not the stress is accidental or planned, so accidental would be maybe you broke a bone on accident or you were in a trauma, or stress that's planned, think of a surgery that you knew was going to happen. And either way, the body reacts to it. And during starvation times, the body's metabolic rate will slow down and we're in a hypometabolic state. But during severe stress, our body's metabolic rate is going to rise. And now we become hypermetabolic. This hypermetabolic response to stress is going to involve most metabolic pathways with accelerated metabolism of our lean body mass, negative nitrogen balance, and muscle wasting. And once the systemic response is activated, the physiologic and metabolic changes that follow could lead to septic shock. So, like we saw in the last chart, the body's response to stress is in two phases. It's the ebb phase, which is the immediate post-injury, And during this ebb phase, we have decreased oxygen consumption, tissue hypoxia, decreased cardiac output, hypothermia, and lethargy. Insulin levels also drop because glucagon levels become elevated. Let me say that one more time. Insulin levels will drop because glucagon levels become elevated. Now, what is the major concern? We are trying to maintain cardiovascular effectiveness and tissue perfusion. Now, as the body responds to the initial injury, we are now in the recovery phase or the flow phase. This is where it begins, and it's usually about 36 to 48 hours after the injury. This phase follows fluid resuscitation and is characterized by increased oxygen consumption, which will also, you'll also see increased body temperature or hypothermia. Our cardiac output increases, as well as nitrogen excretion. We're also going to see expedited catabolism of our carbohydrates, proteins, and triglycerides, and it's all trying to meet the higher metabolic demands. We're also going to see a very marked rise in glucose production, free fatty acids, and circulating hormones like insulin, glucagon, and cortisol. Recovery usually lasts days, weeks, or even months until the injury is healed, and it's really based on the level of injury in the initial phase. Now, multiple stresses can result in increased catabolism and even a greater loss of body proteins. And if the patient is in poor nutritional status before, let's say, the stress of a planned surgery, they're at greater risk for developing pneumonia, wound infections, fever. In starvation, energy requirements will be met from endogenous sources within the body. If our patient isn't allowed or able to take on exogenous sources like food. Intercostal muscles become depleted. We talked about the potential for pneumonia, and inadequate amino acid levels will impair antibody production. If we have impaired antibody production and immune response to infection is slowed, this puts our patient at risk. Both conditions are negative impacts on our metabolic demand. The nutrients that are affected by the hypermetabolic stress are our proteins, vitamins, and our minerals. They're also concerned about total energy and fluid intake. So when our body is in times of metabolic stress, the protein requirements have to increase from 0.8 grams per kilogram of body weight, which is the normal recommendation for a healthy adult. We need to increase that to 1 to 1.5 grams per kilogram of body weight. In severe times of stress, think of thermal injuries exceeding 20% of the total body surface area, or a deep pressure ulcer. During these times, our protein requirements may even rise to 1.5 to 2 grams per kilogram of body weight. Now, these levels allow for protein synthesis if sufficient energy is provided from carbohydrates and fat. Extra fluid may also be required. Well, what about vitamins and minerals? These requirements will also increase during stress. Tissue repair especially depends on having enough vitamin C, zinc, calcium, magnesium, manganese, and copper. The DRIs, or the dietary reference intake levels of nutrients, should be consumed, preferably from foods. However, sometimes we will need to maintain the DRI by tube feeding rather than supplemental forms. Being able to achieve the requirements through food provides sufficient energy to meet the increased demands during critical illness and maintains the integrity of the GI tract and its microbiota. Now, fluid requirements during these hypermetabolic states really depends on age and body composition as well. So for adults younger than 55, our fluid needs are calculated at a rate of 35 to 40 milliliters per kilogram of body weight. In adults between ages of 55 and 65, they require a lower amount of fluid, so only 30 milliliters per kilogram of body weight. Let's detail protein metabolism. Now, even if adequate carbs and fat are available, our skeletal muscle protein is being mobilized for energy, in the sense that amino acids can convert to glucose in the liver. There is decreased uptake of amino acids by muscle tissue and increased urinary excretion of nitrogen during this time. In our highly stressed patients, 1.5 to 2 grams per kilogram a day is given to start. We have to monitor them very closely, and we're looking at their N nitrogen balance. To date, we don't have any studies that demonstrate a significant difference in the infection rates, the length of stay, or the mortality rates based on the level of protein intake or the method of protein that is being delivered. So something to think about. Now, there's some non-essential amino acids because conditionally essential amino acids are still needed during metabolic stress. And these conditionally essential amino acids are arginine, cysteine, glutamine, glycine, proline, serine, tyrosine. They all fall within this category. What happens to our carb and fat metabolism during stress? During carb metabolism, hepatic glucose production increases, insulin levels and glucose are increased. Generally, carbs should provide 60 to 70 of our total calories, keeping in mind that parenterally the maximum rate of glucose oxidation is 5 to 7 milligrams per kilogram every minute, or 7 grams per kilogram a day. And you shouldn't overfeed. Now, our blood glucose levels of our patients need to be monitored closely, adjusting nutrition and insulin regimens, trying to target the serum glucose level of less than 150 milligrams per deciliter. And to support hypermetabolism and increase gluconeogenesis, our fat is mobilized from adipose stores. This is through a process called lipolysis, and lipolysis provides energy. Lipolysis results from elevations of catecholamines, which we know occur, with the concurrent decrease in insulin production. So if we're in a hypermetabolic state and these patients are not fed during this period, fat stores and proteins are going to be rapidly depleted, and this malnutrition increases the susceptibility to more infection, as well as the ability to contribute to multiple organ dysfunction syndrome. We call this MODS, and many times MODS leads to sepsis, and sepsis leads to death. Now, fat administration should suffice to prevent essential fatty acid deficiency and to also provide extra energy. Generally, our fat should provide 15 to 40% of our total calories, depending on our body structure. And however, in patients during times of stress, the feedings high in long-chain fatty acids may cause immunosuppression. So formula should include, instead of these long-chain fatty acids, they need to include omega-3 fatty acids. Hydration status is also really important. It includes fluid losses can result from times of stress like fever, because we have increased perspiration, or it can cause urine output, diarrhea, draining wounds, diuretic therapy. Any of these things can cause our hydration or fluid status to change and our requirements to increase. An average calculation is 1 to 1.5 milliliters per kilogram expended, or 30 to 40 milliliters per kilogram of body weight. But requirements may be decreased in the presence of heart, renal, or liver failure. So this should tell you, in terms of nursing interventions, that accurate intake and output are essential to your patient care. When energy needs of our patients need to increase, then vitamins and minerals also need to increase. And we have to pay special attention to vitamin A and C, as well as zinc. Now, vitamin C is crucial for collagen formation, as well as wound healing. And this should kind of make sense to us if you use skincare products. Lots of vitamin C in these skincare products. Now, supplements of 500 to 1,000 milligrams a day are recommended, as well as vitamin A and beta carotene. Beta carotene is the precursor to vitamin A. It also plays an important role in healing as well as being an antioxidant. And zinc increases tensile strength. Tensile strength is the force required to separate edges of a wound. Now, supplements of zinc sulfate can be given orally at a dose of 220 milligrams per day, and it may be used when patients are stabilized. Also, zinc can be necessary with large intestinal losses as well as ileostomy drainage. It shouldn't be used for more than 2 weeks at a time because when your body has excessive amounts of zinc, it can have an alternating negative effect by suppressing your immunity. Sepsis and septic shock cause a dramatic response to infection as well as life-threatening organ dysfunction. Think about the liver. It plays a central role in managing the immune defense. So when someone has cirrhosis, for instance, they're going to be at a high risk for organ failure or death when they're admitted because they're at an increase of acute bacterial infection or hepatitis. These patients may need immune-enhancing formulas to reduce infection complications. These patients are usually critically ill. We can use indirect calorimetry as a standard for determining the resting metabolic rate, or RMR, in our critically ill patients. And this calculation is based on measurements that is more accurate than our estimates from other predictive equations. You can use a handheld device to help determine this resting metabolic rate, the RMR. And registered dietitians, including and in collaboration with the medical team, they use these tools or formulas to determine energy requirements. And not that you need to know what that formula is, but know that there is a formula for the basis of their decision making. What happens to patients during surgery and trauma? Now, in a perfect world, we would hope that all patients that are undergoing surgery would have an optimal nutritional status to begin with in order to tolerate the stress of the surgery and the temporary starvation that will follow the procedure. But it's very often that these patients are malnourished secondary to the condition requiring the surgery in the first place. So after surgery, they may experience anorexia, nausea, vomiting, and therefore their oral intake will also decrease. There's a chance that fever will occur, which will increase metabolic rate, or nutritional needs may not be met because of malabsorption that occurs during this time. So in order for these surgeries to be successful, our patients that are malnourished, they have to be identified early by the team so that we can have a preemptive intervention or corrective action can be arranged. Undernutrition can actually lead to a decrease in protein synthesis, weakness, organ failure like MODS, or even death. Once our patients are admitted for surgery, think about what we do. We put them on an NPO status, or nothing by mouth, and this is usually 8 hours before the surgery. Oral intake is generally resumed within a day after surgery, depending on what the post-op diet order is, and diet as tolerated is usually for most patients. But some surgeons still prefer that their patients are on a liquid diet, but it's not mandatory, just recommended. However, during bariatric surgery for patients with a body mass index that exceeds 40, or individuals with a BMI exceeding 35 who have other comorbid conditions, bariatric surgery might be a treatment for them. And it does require a multidisciplinary approach. And in your Med Surg 2 class, you'll be talking about the different types of surgeries for bariatric intervention. And the Roux-en-Y gastric bypass is pretty common. It's also used to resolve type 2 diabetes with morbidly obese adults. And you can see in this table the dietary sequence that occurs after bariatric surgery, and it really needs to be followed because there's consequences. Now think about the surgical procedure causing weight loss because it's restricting the amount of food the stomach can actually hold. Well, this also causes malabsorption of nutrients. And when you have a combination of both gastric restriction and malabsorption, then you really have to think about the timing as well as the intake. And so you can see here that the diet order that's suggested here is clear liquids, no more than half a cup a day, 1 to 2 days after surgery. Then progressing to full liquids, no more than 3/4 cups total from day 3 to day 21. Then they can start on pureed foods, and then 6 weeks after the surgery and on, you can go back to a regular diet of solid foods, but you're eating only small meals and snacks, no more than a cup total, and no more than 2 ounces of meat. So this is something that your bariatric patients that are electing the surgery need to be counseled on. Now, there are some other high-risk procedures to consider, like hip replacement, open heart surgeries, prostatectomies, and patients that are undergoing these high-risk surgical procedures or are at a higher risk for malnutrition. They have significantly longer lengths of hospital stays and higher mortality rates. And therefore, our post-op nutrition and or pre-op and post-op nutrition has to be carefully managed and planned. Patients that undergo traumatic brain injury are severely hypermetabolic as well as catabolic. Now, in more severe cases, there is a greater release of catecholamines and cortisol and greater hypermetabolic responses that will occur. These patients need a swallow evaluation as well before they can start oral feeding to determine if it's safe or not, depending also on the level of spinal cord injury. You might also consider these patients needing a recovery plan that can go months and months and months, very much like TBI patients also. But with patients with TBI and spinal cord injury, they need lower calorie intake to prevent excessive weight loss. Look at what can occur in moderate and severe TBI. Physically, there could be a loss of consciousness, amnesia, headaches, migraines, vertigo, dizziness, light and sound sensitivity, seizures, blurred vision, dry eye, and chronic pain. They also go through cognitive and emotional changes as well. With their cognition, they may have a diminished attention span, impaired decision-making, lack of impulse control, trouble concentrating, memory lapses, and confusion. Emotionally, they can have trouble with anxiety, apathy, aggression, depression, personality changes, and post-traumatic stress. Systemic inflammatory response syndrome, also known as SIRS, is a time when our inflammatory responses and tissue injury occurs in infection, pancreatitis, ischemia, burns, traumas, shock, and organ injury. For diagnosis, the site of infection has to be established already, and at least 2 of the following also need to be present. So you have to have already established that there is a site of infection, and one of the next 2 things: body temperature over 38 degrees or under 36 degrees Celsius, a heart rate greater than 90 beats per minute, a respiratory rate greater than 20 beats per minute, so they're tachypnic, or a PaCO2 under 32 millimeters per mercury. This tells me that they're in a hyperventilation state. If their WBCs are over 12,000 or under 4,000, you can consider SIRS. Now, patients with SIRS are also in a hypermetabolic state, so their nutrition needs will increase significantly. The benefit from early tube feeding with this situation is important, especially in critically ill patients. We use enteral versus parenteral, versus the parenteral type feeding because we're trying to reduce infection complications and length of stay. The total volume and total energy restrictions may also be considered. They're necessary to understand, especially if someone also has hyperglycemia, you might need to add insulin as needed. So the important aspect here is to know what is the definition and how patients get diagnosed for SIRS, systemic inflammatory response syndrome. With MODS, or multiple organ dysfunction syndrome, this involves the progressive failure of 2 or more organ systems. So, like the renal and the hepatic, or the renal, hepatic, and cardiac, or the renal, hepatic, cardiac, or respiratory systems. Just 2 or more at the same time. Unfortunately, our patients that are chronically critically ill and are in the intensive care, this has been now an epidemic of sorts, because these patients are going to increase length of stay with a persistent dysregulated immune response, causing persistent inflammation, persistent immunosuppression, and persistent catabolism syndrome. Now, the elderly patients are going to be more vulnerable to any illness, and we know that they are at a high-risk population for MODS. This pathogenesis of MODS is quite complex. We start with gut barrier failure. This is associated with this bacterial translocation. We also have systemic inflammation and the development of multiple organ dysfunction syndrome. And the uncontrolled inflammatory response can lead to not only lung failure, but also liver failure, intestines, and kidney failure. Heart failure generally manifests later, but central nervous system changes can happen at any time. During this time, in terms of our nutritional needs, there will be an increase for protein and just our kilocalories in general to meet increased metabolic demands. Early enteral feedings appear to maintain gut mucosal mass and barrier function as well. It also will help promote normal enterocytic growth within the gut. Our patients that have suffered from a burn injury, which can be defined as either 1st degree, 2nd degree, or 3rd degree, depending on the thickness of the injury, can also be in a metabolic state of nutritional dysfunction, because burns produce tissue destruction that results in circulatory and metabolic alterations. This requires compensatory responses to the injury itself. Major body burns have significant effects on nutritional status because the stress response is so heightened, and it causes prolonged metabolism and also long periods of muscle wasting. Now, thermal burns are usually characterized as contact burns. Think about holding something hot in your hand. Flame or scald injuries. So scald injuries would be like heated liquid. Flame would be if something was openly directed in the flame of the fire. And so in contrast, non-thermal causes of burn would be chemical, electrical, and radioactive sources. Take a look at 1st degree, 2nd degree, and 3rd degree here, which you'll go into more depth in your med-surg class, but very basically, 1st degree burns are partial thickness burns. You'll see reddening of the area to the injury, and you might see some subacute tissue, and it takes 3 to 5 days to heal. Usually doesn't leave any scars. A 2nd degree burn is a superficial partial thickness injury and a deep partial thickness injury. You might have some reddening and blistering, and it can take weeks or months to heal. Versus a 3rd degree burn may require skin graft. It doesn't heal very well. There is a full thickness injury causing destruction of the entire epidermis, dermis, and the underlying subcutaneous tissue. When we take care of burn patients, the nutritional goals are quite different from any other situation. You can see that pain management as well as wound care and infection control are important. But nutritional support has to come in to bolster the patient's ability to heal. Without proper nutrition, we have poor wound healing. First 24 to 48 hours are just dedicated to fluid and electrolyte resuscitation and replacement. The fluid needs are based on age and weight and the extent of the burn, and you're also looking at the total body surface area, which is the amount of body, it's an estimated number, that allows us to know the extent of the burn. And you can also use the rules of 9, and the rule of 9 is that the head is worth 9%, upper limbs are both equating to 9% each. The trunk, it's 9 times 4, which is 36%, and the lower limbs are 9 times 2, so 18%. So that's the rule of 9s. But this allows you to determine the severity and also how to determine how we are going to approach their nutritional care. Now, thermal injury wounds will heal only when the patient is in an anabolic state. At this time, feedings can be initiated as soon as the patient is hydrated. Very early enteral feedings may actually decrease the hypercatabolic response. And it is just an estimation of energy and protein needs, but we're trying to promote good wound healing. So then additional protein needs need to be met. We also, again, like we've talked about previously, we have to pay attention to vitamin A and vitamin C. You can see that the nutritional goals for patients with burns are outlined in this table. We're trying to support the role of the skin. We're trying to reduce bacterial and virus infections. We need to meet the accelerating nutritional needs, prevent micronutrient deficiencies. We don't want an ulcer to develop, and we're trying to manage states of hyperglycemia. You can see that early enteral nutrition may allow us to meet the following objectives. It helps to meet the nutrition needs of our burn patients. It helps to improve feeding tolerance, decrease incidence of bacterial translocation, decrease the number of infectious episodes, decrease antibiotic therapy, improve nitrogen balance, reduce urinary catecholamines, diminish serum glucagon, suppress hypermetabolic responses, and enhance visceral protein status.